Foundation CME webinar series. Today's topic is on non-pharmacological interventions for insomnia in older adults and those living with dementia, and is certainly of great interest to many of our community-based practitioners. Home Nursing Foundation is the largest home healthcare charity in Singapore, providing home-based medical, nursing, therapy, and home personal care to more than 5,000 frail and vulnerable patients each year. And we also run 2 senior daycare and community rehab centers at Hougang and Buangkok, with an active aging center to serve the needs of those who are well as those who are dependent and frail. Under the prolific clinical leadership of Dr. Ng Wai Chong, this series of continuing professional education was started in 2022 to raise our understanding and practice of holistic medicine in the community, and also provide support to caregivers so that our patients and our residents can live joyfully and age well in the community. Over the years, we have covered a wide variety of topics, highly pertinent to many community aged care practitioners, such as end-of-life care, functional rehab, dementia, falls, mental health, Parkinson's, and wound management, caregiver support, social prescribing, just to name a few, and also invite you to go to our YouTube channel to help yourselves to these webinars that were recorded. This afternoon, we are eagerly looking forward to the sharing by Zaylea, who has very kindly and generously agreed to spend her precious Saturday afternoon to share with us on this interesting topic. I'll pass the time over to Dr. Ng Wai Chong to introduce Zaylea.
Thank you, Christina. So, yes, we're very happy to have Zaylea with us again for a very interesting topic on insomnia. So the last time she came was 2 months ago when she shared about non-pharmacological approach to anxiety and mood disorder. And this time round, we discussed a bit on insomnia, and actually it's a very rich discussion. We couldn't finish it then. So we decided to have one devoted just for insomnia, because it's a very common issue that all of us face working in the community, dealing with older persons, especially those who are frail, and because it can be a source of a lot of stress to caregivers. So I'd like to introduce Zaylea. So Ms. Zaylea Kwa is a senior clinical psychologist who have many years of experience working with people experiencing psychological distress. She was awarded the Ministry of Healthcare Graduate Studies Award to pursue her master's degree in clinical psychology in University of Queensland, Australia. And she has experience working in public and private healthcare sector. And she specializes in geriatric psychology, where she conducts neuropsychological assessment to assess differentials of cognitive impairment and support the management of behavioral and psychological symptoms of dementia. Now she has a solo practice where she partners GPs, psychiatrists, and neurologists to support patients and caregivers with their mental health and cognitive concerns. So today, our topic, as Christina has shared, non-pharmacological management of insomnia among older adults and persons living with dementia. And I will also be co-presenting with Zaylea, but my role is really supportive. I like to present 2 cases. Both of them were my own patients, and just to hear her insights about it. The first case is not strange to unfamiliar to many of you because I presented it earlier. So I'll talk about it briefly. The second case is a gentleman with dementia. So I'll share the 2 cases first, and then Zaylea will deliver her lecture. The purpose of the case study is so that all of us here, many of you in the audience are clinicians. I think we learn better with a case in mind. So I will share the case studies with you first, and then we'll hear the main topic today on non-pharmacological approach. So this case was presented 2 months ago. It's an 88-year-old gentleman living at home with his family. He was ex-Chinese teacher with 2 sons and a daughter, lives with the elder son and his family. His wife has severe dementia. There are 2 helpers at home in a landed property. He enjoys food and driving around town. Just two days ago, he had a URTI, so I went to visit him. He's now driving, So when I first saw him, he was quite ill. So you can see from the history I'll be sharing. CKD over 40 years, impaired glucose tolerance, hypertension, BPH. and he had recurrent admission in 2023 with blocked common biliary duct sepsis, complicated surgical intervention, and then had GI bleeding and acute GE, septic shock, stroke. When I first saw him, that was the time when he had the stroke. He refused to go to hospital. So I assessed him at home. In the end, with some counseling and discussion, he went to hospital, but the hospital was well managed. He came back better. And so now it's been 2 years now. He's really doing very well, putting on weight, attending active aging center with our AACs, and he's driving around, which is his hobby. So since I saw him, there's home visiting therapists, and he's now driving. So CFS at that time when I saw him was CFS 6. Gradually he became 4, and no cognitive impairment. Mood was low, frustrated, demoralized. The main issue was poor sleep with nocturia 4 times overnight. And in the daytime, at night when he cannot sleep, he thought a lot about the old days and existential issues. So the family sometimes, like, they ask me to do some kind of counseling for him, but I'm not a counselor, but I just chatted with him, shared with him positive stories about successful aging and so on, which I think he benefited him. So so this was my diagnosis, and at that time this case was presented about low mood and insomnia. Currently, he takes melatonin off and on, and he has just accepted his insomnia without, I mean, he still has it. Zaylea, the last time when we heard from Miss Kwa, she shared a lot about the sleep pattern and stages of sleep. So this time around, perhaps we can hear more about how we can manage someone with insomnia like this. The second case is a new one. Okay, so this is a 90-year-old Malay gentleman with dementia and sleep weight reversal. So I understand many of you in the audience also work in nursing homes. So this may be familiar to you, a typical, maybe someone typical that you might have seen before. Not, of course, the patient itself, but cases like this is not uncommon. Those who work in nursing home will know. He was admitted to this nursing home in 2013. Before that, he was living in a destitute home. That was 2007. So imagine for 18 years, he has been living in a care home. Okay? So he was divorced. There are no children. According to a nursing home, there's nobody visiting, nobody calling, and there's no sponsors or NOK that they can actually talk to. He talks about a son in Batam, okay, but there is no way for the nursing home to ascertain or to contact the son in Batam. He enjoys going for community outing because the nursing home sometimes organize it for the residents. So past medical history, not atypical, high blood pressure, hyperlipidemia. So everybody more or less is quite common, except that he doesn't have diabetes. But these are all age-related conditions. There's chronic kidney disease, most likely due to hypertension, since at least when he was enrolled into this nursing home. There was anemia that was investigated. There was some gastritis, but now he's stable. There was also cognitive impairment with a history of sexual disinhibition at the nursing home. So there was a visiting psychiatrist in that nursing home who diagnosed him to suffer from dementia with frontal lobe impairment. And ultrasound was also done sometime suggestive of liver cirrhosis, but now it's been more than 10 years. The liver function is like not creating any issue. So what about the other functions, right? So his ADL, when he came in 2013, it was 98 MBI upon 100. So this is almost totally independent. Now, about 11 years later, it has dropped to 54, moderately dependent. He can still walk with 1 to 2 person assistance. So, but because the dementia, you can see the AMT recently done in dementia, in December last year, was 0 upon 10. So you can imagine a person with severe cognitive impairment who is able to walk and who may wander, and there's a risk of falls and other things. So his dependence is probably related to his cognitive impairment. Fast staging, I estimate it to be around 6C. He wouldn't be able to dress himself or understand the mechanism of showers or use the toilet himself, but he would, if he wants to go to toilet, he would stand up from the bed and somebody can guide him. So I would say probably C to E. Probably he knows his urge to pass urine or pass motion. The main issue that the nursing home grapple with is the sleep-wake reversal. Since 3 years after his admission into the nursing home with sexual disinhibition, especially at night. So what was described was taking off all his clothing at night. But fortunately, in that nursing home, the whole floor is all male patients, residents, and the nurses, I mean, they are not offended by such behavior, so they could deal with it without overdosing it with medicine. But the poor sleep at night, sleeping in the daytime, and so on, the poor sleep at night sometimes can disturb other residents. So over the years, I saw the doctors have added fluvoxamine, risperidone, epilim. So all these medicines are just to help him to sleep better at night, but it hasn't been working very well. So he's still sleepy in the daytime. So the question I like to pose for our speaker today is, how can we manage a person with dementia who can't sleep at night, which is so common? And at home, they'll stress out the caregivers. In a nursing home, it may stress the nurses, and sometimes when there is lack of manpower, they may be restrained, which of course is not the best thing that we can do to our residents. So Zaylea, maybe you could guide us on these two cases as an example and share with us about insomnia approach.
Okay. Thank you, Dr. Ng, for introducing this complicated case. Although, like you say, it is quite commonplace to see this kind of cases. So I do see similar sort of cases in my practice as well, both for patients without dementia and with dementia. And their management is somewhat different. So I'll guide everyone through these two topics for today. Okay, so let me just bring up my slides first. Okay. So once again, thank you so much for having me here in sharing ways, specifically non-pharmacological management strategies of insomnia for older adults and those living with dementia. It is very important for us as healthcare professionals to also clarify our own beliefs of sleep. And therefore, I'm going to present to you some statements about sleep. And I'd like you to tell me whether you think it might be a myth or a fact about sleep. So the first one is that sometimes we might think, oh, that I can try to sleep more. Example, sleep in during the weekends to make up for lost sleep. Can you type in the chat, do you think this might be a myth or a fact? That if you were to sleep more during the weekends, would that make up for lost sleep? You can type in the chat to let me know whether you think it might be a myth or a fact.
As an organizer, can I check with Jamie? Can we allow the participants to? Oh yes, I can see people
I can
commenting
see
already.
someone.
Thanks.
Yes,
Yeah.
thank you. Yeah. Okay, thanks so much, Donna, Huali, Jen, Shavin, for your response. Thank you. Yes, you're absolutely right. So if we were to sleep more during the weekends, it can actually start to establish for us an irregular sleep pattern. And this might actually cause us to disrupt the brain's circadian rhythm. And you know that the circadian rhythm is very important for us to be able to maintain consistent and restorative sleep. So some of us might also try to sleep more during the weekends to compensate, but it's actually more effective for us to have a consistent sleep and wake time, which I will talk about later as well. Okay, so the next one that we see is that exercise will make me more alert and I won't be able to sleep at night. Do you guys think whether this is fact or not? Okay, so this is also a myth because even though some people might think that exercise can make them more tired and they would sleep better, but if you were to do very vigorous exercise right before your sleep, it can actually increase your alertness. Hence, it might be better for us to engage in more moderate levels of exercise earlier in the day to help with our sleep quality. And some studies have also shown that if we were to do more moderate exercises, it can help you to fall asleep faster and also have deeper levels of sleep too. Okay, let's look at the next one. Okay. Thanks, Mingwek and Varadan, also for contributing your answers. Okay, so this next one is actually also a myth. And what we're saying is that if we think that we want to relax, right, after a long day of work, very tiring, we want to relax by reading or watching television in bed first before sleeping, this can actually cause you to create a mental association that the bed is meant to be used for other activities besides sleep. And this will make it harder for us to fall asleep. And a lot of our older adults these days, they might end up watching a lot of television in their bed before sleeping, um, especially those in the nursing homes, right? I mean, they spend a lot of time in bed already, but even before sleep, they might also be watching the television or doing some reading before sleep. And this can create a mental association that the bed is meant for other activities and therefore making it harder for them to fall asleep. Okay, so taking naps can help with my insomnia, right? So the thing is that a lot of our older adults do take naps, and if you find them napping, especially late in the day, after 3 to 4 o'clock, then it can have the impact of interfering with the nighttime sleep because it sort of messes up with a person's circadian rhythm and also messes up with the sleep depth. So a sleep depth is something that we want to accumulate further and further into the night. However, if you are already napping late in the day, then this can take away some of that sleep depth, making you less tired and interfere with the nighttime sleep. Okay, the last one is drinking more coffee can help to make up for my lack of sleep. I'm personally guilty of this also, sometimes using caffeine to make up for, poor sleep or just feeling tired. However, relying on coffee can also disrupt our natural sleep cycle and leading to difficulties falling asleep later. So if any of you do have these beliefs or thoughts about sleep, it's good for us to clarify these thoughts so that we can provide the right and accurate information for our patients and clients. Okay, so I want to first spend some time revisiting some of the content that I've covered in the last session in case you might have missed it. Firstly, it's important for us to know how sleep might change as we age. Then I'll talk about how sleep can have an impact on our health and what are the things that older adults can do to sleep well. I'll first talk about what we can do to help older adults without dementia to sleep well, and then I'll end off talking about some strategies that we can implement for those with dementia. Okay. So this is a normal pattern that we might experience in terms of sleep changes with aging. Firstly, there will be a circadian rhythm shift. And what this means is that typically for middle-aged adult, for example, younger and middle-aged adult, they might feel sleepy about 10:30 to 11, and they might find themselves waking up about 5 or 6 o'clock. However, this circadian rhythm tends to shift forward with aging, and as the older adults increase in their age, they might experience an advanced phase of sleep cycle whereby they might feel sleepy as early as 6 o'clock and then experience wakefulness at 3 or 4 a.m. So the thing is that we need to expect such advancing in circadian rhythm to happen because sometimes caregivers might complain of older adults waking up at 3 or 4 a.m. but actually that corresponds with their correspond with these changes of sleep patterns along with aging. So sometimes we need to be able to educate what are the expected changes of sleep schedule with aging so that our caregivers know what are some things to expect as well. and that they do not criticize or kind of scold their loved ones for waking up too early, when actually this is the normal waking time for them at about 3 to 4 o'clock. Okay, there are also some changes in our sleep architecture, and we know that with sleep, it is actually divided into several stages that are important to take note of. Firstly, we start off by being awake, and then we go into this stage 1 of sleep, whereby we start to feel quite drowsy. And you might also experience this yourself, where you fall between this state of sleep and wakefulness. Gradually after the first stage, you will then fall into a stage 2 of sleep, whereby it is a light stage. And in this stage, it could be a sound or it could be a light that is switched on. Someone can be very easily awakened during this light stage of sleep when there are such disturbances. Following stage 2, a person will then go into stage 3 and stage 4, which is what we call a deep sleep. And the deep sleep is most critical for replenishment of our physical energy, as well as for our immune system. So that is usually what we are trying to aim for. And the REM sleep is important for our cognitive abilities. The REM sleep is called a rapid eye movement stage of sleep. And this is where we tend to dream a lot, because during this dream process, our memories are actually being restored and reprocessed to help us consolidate more for our learning and our memory. So this is actually a process of a young adult, where they spend the first 1 to 3 hours so going through the 4 stages of sleep. And then as the night progresses on, they actually become more at the stage 2 and the stage 1. So of course, as we are becoming more and more alert as the morning comes. Now, taking a look and comparing to someone who is an elderly, you can see very, very stark and significant difference between the sleep architecture of a young adult and the elderly. Firstly, the deep sleep that we see for stage 3 and 4 diminishes dramatically to only 3%. From 25% of the total sleep time, meaning that it is going to be quite seldom for an older adult to be in that deep sleep stage. Secondly, light sleep also increases, right? They are spending more time, as fast as 1.5 to 2 hours after falling asleep. They are already in the light sleep stage. So it is very easily for them to be aroused or awakened during the sleep. And therefore, it's very important for us to make sure that the sleep environment stays quiet and dark for them to be able to maintain the sleep throughout. Otherwise, they will be easily awakened during the hours that they are spending asleep. The third thing is that there is a decreased continuity of sleep, in the sense that you see that there are very frequent fragmented sleeps. There are more frequent awakenings in between the hours and the sleep cycle. So whereas in a young adult, they might be able to go back to the stage 2 and stage 3 of sleep. However, for an older adult, there are many, many frequent awakenings over here. There is also a decrease in REM sleep, which will contribute to some cognitive issues and memory decline as well. So these are just some of the things, once again, for us to educate caregivers also, because it's important to adjust our expectations to what an older adult can or cannot sleep. If we expect them to sleep like us or like a young adult, then we can often feel very frustrated in our care, because that is basically not how their sleep architecture is working. Okay, so in terms of sleep duration, whereas for young adult or middle-aged adult, we might require 7 to 9 hours of sleep. 6 hours work as well. However, for older adults, 5 to 6 hours are typically already sufficient for them. So we might experience a reduced need of total sleep time for older adults too. Okay, next, they also experience a decline in their sleep efficiency. And what this means is that, so how we calculate sleep efficiency is we take the formula of times spent asleep divide by time spent in bed. Okay, time spent asleep divide by time spent in bed. So let's say if you're spending very little time asleep and a lot of time in bed, then you would be more likely to have very low sleep efficiency. So a lot of our older adults, we are finding that they are spending too much time awake in bed and very little time asleep. So this leads them to have very low sleep efficiency, whereas we are trying to aim for a sleep efficiency of 85% or higher. That is usually considered normal. So we want to increase the time that they are spending asleep and decrease the time that they are actually spending awake in bed. Okay, now talking about disordered sleeping or sleep disturbances, firstly, we will have to, of course, consider insomnia. Okay, so you can see that the prevalence for insomnia actually increases over the lifespan. And in fact, women seems to be experiencing more insomnia as compared to men. And when we are looking at the prevalence of insomnia among people with health conditions, you can see that those people insomnia is very prevalent among people with health conditions like cancer, diabetes, high blood pressure, chronic pain as well. Especially things like chronic pain and high blood pressure, there's a significant difference in people with and without insomnia. And actually, these two are two very common medical conditions that will contribute to people having insomnia as well. Okay, so what is insomnia? We are actually looking at the sleep quantity and sleep quality when we're talking at insomnia. The first two criteria that people have to meet in order to be diagnosed with insomnia is that they need to have difficulty falling asleep or staying asleep. They may also have early morning awakenings with an inability to return back to sleep. So sometimes we have awakenings in the morning, that's fine. However, if someone have an inability to return back to sleep, then we might classify them as having insomnia. Also, this needs to happen at least 3 nights per week, not just happening like once a week or once every 2 weeks. It needs to be of a certain frequency level that is corresponding to at least 3 nights a week. This sleep difficulty should also be persistent for at least 3 months. And the sleep difficulty needs to be occurring even though people have sufficient opportunity for sleep. It's not like, let's say, for us, if we are working night shift, for example, and there's not enough opportunity for us to sleep, of course, we are going to have some sleep difficulties, and you may not consider that as insomnia. For someone to classify as insomnia, the sleep disturbance should also impair their daytime functions, such as having excessive daytime sleepiness, feeling very fatigued, feeling that their mood is affected, for example, feeling more irritable or feeling more worried about not being able to fall asleep. They should also have some impairments in their cognition, such as trouble concentrating or paying attention. So if an older adult without dementia falls into such a criteria, then we can consider them to have insomnia. Okay, so what are some of the impact of disrupted sleep? Of course, sleep has such a significant impact on our daily functioning as well as our cognition. It can impair our attention, slowing down our processing speed and response time. It may also impair our memory and concentration, decreasing our performance of our ADLs. And studies have also shown that it can increase the likelihood of mortality, whereby the causes of death is 2 times higher in older persons with sleep disorders. So it is something that we need to intervene in a timely manner. So how is it that we can enhance our sleep? And these practical tips that I'm going to share with you can be used for both older adults with and without dementia. The first thing that we can educate our patients as well as the caregivers is to cultivate a healthy sleep hygiene. And what this means is having a strong sleep hygiene means having a good bedtime environment as well as a good daily routine that will promote consistent and uninterrupted sleep. So let's take a look at some of them. Okay, so some of the sleep hygiene practices that I would definitely advocate to my patients and my clients is first is to have a fixed sleep time and wake time. Now, very often you will find patients coming in and telling you that sometimes they sleep at 12 a.m., sometimes they sleep at 2 a.m., or sometimes they go to bed at 10 p.m. If they are telling you such irregular sleep patterns, then this is a sign to us that we need to schedule and almost prescribe a very regular sleep and wake time for them. Maintaining a consistent sleep and wake cycle is very important to help us to regulate our circadian rhythm, such that we are going to bed and waking up at the same time every day, even on weekends, so as to help regulate the body's natural clock. So this is the first thing. If you notice that your clients are having irregular sleep patterns, as you kind of assess and question what is their sleep time, what is their wake time, this is a problem. The first thing to do is to set a regular sleep and wake time for them. The second thing is to try to incorporate a consistent bedtime routine, and this can include a soothing bedtime routine, such as having a warm shower, reading a book, listening to soothing music, to signal your body and your brain that it is time for us to fall asleep. So I'm not sure whether nursing homes have this sort of routine or not, because very often I see that our nursing home residents take a shower and then they are already in bed way before it's time for sleep time. So maybe incorporating some kind of a bedtime routine can also be helpful. Okay, winding down. All right, so we need to budget about 30 minutes to allow our body to go into that state of calmness. And we can do this through some light stretching and sleep meditations also. Okay, so on the right-hand side are some relaxing sleep meditations that we can do. Maybe some older adults with limited mobility can also try to do. So stretching in that seated cat or cow position, doing some neck stretches, doing some overhead reach, twisting, through our upper body. Okay, arcing our back like this in a fish pose, and also bending forward. So we can repeat some of these light stretching routines over 5 minutes or over 3 to 4 sets of it, in order to once again prime our brain that it's time for us to relax and go into the sleep mode. So these are all different things or strategies that we can teach to our clients and patients. The next thing is to make sure that the sleep environment is optimized. So very often I note that, of course, in the nursing home environment, it's hard to cater to the individual need, and oftentimes it is also not very quiet, because there could be next door neighbors that are making loud disturbances. But as much as possible, we want to make sure that the elderly is able to have a dark, quiet, and cool environment that is conducive for sleep. If someone else is disturbing, they may be able to use a earplugs, or if the light is still switched on, then we can recommend the use of eye mask, for example, as well as adjusting the fan or aircon to make sure that the room temperature is comfortable for them. So this is to help us optimize a sleep environment. Second, this one might apply a little bit more for home care clients. So we don't want to encourage any toss and turning. If the older adult is not able to fall asleep, then we want to apply a 20-minute rule. What is this rule about? So if we are unable to fall asleep after 20 minutes, we want to tell our caregivers to encourage the elderly to get up and do an activity that is very calming, or in a way very boring, outside of bed. It could involve reading a very boring book, for example, or doing I would say doing something that is calming, let's say a sleep meditation, or doing something boring, such as reading a mathematical textbook, for example. We want to avoid doing any activities that is mentally stimulating. So the idea is that if the person still cannot fall asleep after 20 minutes, then we don't want to make it a struggle for them to stay in bed, because the more they toss and turn, the more it's going to prime your brain that sleep is very difficult. The body gets more tense and more stressed out because they are unable to fall asleep. Then the bed becomes not a very calming and relaxing space for them to fall asleep. Next, we want to associate bed with sleep. What this means is that the bed only spend time in bed for sleep. We don't want to spend time in bed for anything else, like using the handphone, watching movies, watching television and all that, because this will reinforce to the brain that, hey, this space, I can do it for anything else besides sleep. So we try to inculcate the idea that bed is only meant for sleep lah. Yeah, although I understand that there are some limitations to this in the nursing home. Okay, now that I've talked about all the sleep hygienes that we can implement during the night for the nighttime routine, what can we do during the daytime? Okay, so we have to incorporate both the nighttime routine and the daytime routine to achieve optimal sleep patterns and to regulate the circadian rhythm. Firstly, for physical activity, we know that regular exercise is actually good for sleep, but try not to do any strenuous exercises 4 hours before bedtime. So for those people who can still walk, we want to encourage them having some morning walks because it will also help them to feel more refreshed and absorb more light, daytime light during the day. Okay. It is quite common for older adults to take naps, and it is okay to take naps. We just want to avoid any naps that will increase the tiredness at bedtime. Okay. Sorry, we want to avoid taking naps so that we can increase the tiredness and bedtime. If the resident or the home care client that you are working with do take naps, then we want to restrict this to before 3 p.m. and preferably less than an hour so that we are accumulating the sleep debt towards the prescribed sleep time. Okay, lastly, for diet, avoid any caffeine found in coffee, tea, or chocolate, any alcohol, cigarettes 4 to 6 hours before sleep, because all these substances are stimulants and it can definitely impact on a person's ability to fall asleep. Okay, so I just want to share a little bit what we usually do for CBT, and these are what psychologists, some counselors, social work also implement, and you might also take away some helpful strategies to help with therapeutic strategies for insomnia. Okay, so firstly, I'll talk about mental associations. I've already covered that briefly. Sleep restriction techniques as well as thought challenging. So these are meant a little bit more for older adults without dementia. I also have a short case to share with you. So this is my patient who is 63 years of age. She was a homemaker and she lives with her husband who works night shift. She enjoys doing cooking. She enjoys playing mahjong with her friends, but she doesn't do any physical activities at all. Okay, so she came to see me because of chronic insomnia. She had been having difficulties falling asleep for more than 3 days a week for more than 6 months. So it is really impacting on her daytime routine. She does see a psychiatrist, which she takes sleep medications for, but she have some worries about developing dependence on the medication. So she comes to me to want to learn she wants to learn some non-pharmacological strategies to manage her insomnia. All right. So, firstly, what I did with her is ask her to complete a sleep diary for me. And a sleep diary is very important so that I can track what her current sleep patterns are like. So for her, she usually likes to watch some Korean drama in bed. She then goes to sleep at 2 o'clock, very late, 2 a.m. She would scroll her phone and then only fall asleep at 3 a.m. She would then wake up at least twice and have difficulty falling back to sleep immediately. She would wake up at 11 o'clock and then only getting up, sorry, at 12 p.m., not 12 a.m. Otherwise, she's spending the whole day in bed. Okay, so this is what her sleep diary is like. So basically, I am using the sleep diary to calculate her sleep efficiency. And in terms of the time spent in bed, right? She's spending in bed 2 a.m. to 12 p.m. That's about 10 hours, okay? However, the actual sleep time, you can see when I actually break it down, it is only about 5.5 hours. So her sleep, right, she was only sleeping 3 to 4:30 a.m. And then after that, she would wake up and only fall asleep 1 hour later at 5:30 a.m. 7:30 a.m. she will wake up again and then only fall asleep 1.5 hours at 9 a.m. So basically, to sum up her sleep pattern, it is an irregular sleep schedule. Sometimes she sleep at 3, sometimes she sleep at 1. It's no fixed sleep and wake time, and there's frequent awakenings. She is also very sensitive to the sounds of her husband coming back to use the toilet as she returns from work. She does not feel well rested at all during the day. In fact, she feels very irritable and gets quite snappy with her husband. She tries to force herself to fall asleep, but becomes very frustrated. So she has some tossing and turning in bed, and she also reported many negative thoughts and worries about her sleep. Okay, so what are some things that I did? Firstly, I implemented a sleep restriction schedule with her, and the goal is for her to increase her sleep efficiency. So just now I show you this chart, right, about how with aging our sleep efficiency decline. So we need to help our patients calculate their sleep efficiency in order to maximize it to about 85%. So how we calculate this is using the formula of time spent asleep divide by time spent in bed. So 5.5 divided by 10 times 100% is about 55%. So this is way below the optimal sleep efficiency. And I drew a kind of a little chart to show you how her sleep pattern is basically like, okay? So this is how she is, 2 a.m. in bed, but only falling asleep 3:30. And then the blue columns are the time she's actually asleep. The yellow ones are the time she's spending awake. So because this is very not ideal at all, where there's frequent awakenings and long time spending in bed, the sleep restriction technique basically advises for us to squeeze and compress all the sleep time together in order to minimize the time spent in bed. Okay, so we want to firstly maximize the time spent asleep, but minimize the time spent in bed. And how we do that is actually finding out how much time she's spending in bed. So she actually can only sleep for 5.5 hours to start off with. And given that she want to wake up at 11, so we started off scheduling her sleep time at 4:30 a.m. So obviously this is very, very late, right? But we want to make sure that she's only sleeping 5.5 hours each day, because that is about the rough time she's spending asleep. And over time, she will accumulate a sleep debt. And when that sleep debt is accumulated, right, she will be able to sleep more. And when that happens, we can slowly start to move her bedtime forward. But for a start, if she can only sleep for 5.5 hours, then we want to restrict that timing to one whole block of it as much as possible. Okay. Yeah, so anyway, we can work towards a long-term goal of having a higher sleep efficiency with our patients. Next is associating bed with sleep. So this is very important. We want to make sure that the bed is only meant for sleep. If the bed somehow become associated with worries, anxiety, tossing and turning, scrolling of handphone, then it becomes a very space it becomes a space that is the opposite of a calming and relaxing space for sleep. So in order to do this, we need to implement some sleep hygiene strategies. So with my patient, I told her that she should only be lying down and sleeping only when she feels sleepy. Do not use her bed for anything else besides sleep. If she's unable to fall asleep after 20 to 30 minutes, get up and do something calming. Avoid clock watching also, because sometimes she might look at her phone and say, oh dear, it's only 5 a.m. and I'm still not asleep. I'm going to be very, very tired tomorrow. And this clock watching is going to increase her anxiety. Okay, so because she's also a light sleeper, easily disturbed by her husband coming in, so I also advise her to use the eye mask and earplugs to prevent the noise interferences. Now, the next important component of cognitive behavioral therapy for insomnia, we have so far talked about the behavioral portions, but it's also important to identify some negative beliefs or thoughts about sleep, particularly with your home care clients. So some of the thoughts that my patient had were, if I don't get 7 to 8 hours of sleep, my day is going to be ruined. I won't be able to function during the day if I'm not well rested. I will be so irritable at my husband, and it's already 4 a.m. and I'm still awake. There's not much time left to sleep. Okay, so it's very important for us to help her challenge and reframe her mindset about sleep. Otherwise, these worries are going to cause her to feel even more anxious and not feel relaxed at all. So how do we go about challenging these thoughts? So some of the things that we tried to reframe her mind of thinking is that, yes, I've only slept for 5.5 hours, but I still managed to function even with that 5 hours of sleep, and I can still complete my daily task of cooking. If I didn't sleep well the last few nights, I am more likely to sleep well tonight because of that pressure to accumulate the sleep debt. In most cases, what is the worst thing that can happen if I don't sleep well? The worst thing is that my mood will just be affected during the day. Okay. And if I awaken after that 5.5 hours of sleep, I would have already gotten my core sleep or the necessary recommended hours of sleep. As I showed you in the chart earlier, actually for older adults, they only need 5 to 6 hours of sleep. But some people have unrealistic expectations of themselves or their loved ones to sleep more hours than that. But it's not necessary. And lastly, there's a reassurance that her sleep will continue to improve as she implements and applies those behavioral techniques. Yeah, so this is kind of like a multi-stepped way for us to work with insomnia from the cognitive perspective as well from the behavioral perspective. Other kinds of relaxation techniques that we can actually teach our clients include things like progressive muscle relaxation, which involves the tensing and relaxing of muscle groups. We can also teach them deep breathing exercises, body scan, and sleep meditation. Okay, so sorry, let me just take a look at the time and see if I have some time to go through the progressive muscle relaxation. Okay, I think I do have some time. So there are so many relaxation strategies that you can teach to your clients, but let me just go through one that I find quite helpful, which is called progressive muscle relaxation. Okay, so the ideology of PMR, progressive muscle relaxation, is that the whole body should be in a very relaxed and calm state in order to feed back to your brain that it's time for us to fall asleep. However, if the body is very tense, it's not going to happen. So we need to intentionally tense these muscles and then relax it in order to create this feedback loop. Okay, so how we do this, let me maybe just go through some parts with you. It might look a little bit small on your screen, but let's try to do this together, okay? So we'll do this from our toes all the way to our head. So firstly, for your foot, right, what you can do is actually curl your toes in, okay? Squeeze your toes, curl it in, and tense it for 10 seconds. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and then slowly release your toes, okay, for another 10 seconds. All right, you should experience the difference between that tense state and relaxed state. Okay, that's the kind of difference in relaxation that we want to experience. So now, if you are seated down on a chair, then you can try tensing your calf muscles as well. How you do this is bend your foot upwards to the ceiling like this. Okay, bend your foot upwards to the ceiling and tense it. 9, 8, 7, 6, 5, 4, 3, 2, 1, and then gently put it back down. 9, 8, 7, 6, 5, 4, 3, 2, 1. So then we can repeat that for many different muscle groups in our body. Okay, the next one that you can try is also with your stomach. So holding your breath. So taking a deep breath and then holding it for 10 seconds. And then slowly relaxing for 10 seconds, okay? We can also try it for our shoulders. So how we do this is you raise it to your ears like this, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And then slowly just letting it down, okay, for another 10 seconds. So you should feel that difference between the tense state and the relaxed state. The next one we can do is for our neck. So how we do that is kind of raise your neck up to the ceiling gently for 10 seconds and then bring it down again. Okay, so we will do this repeated steps for sequence for about 3 to 5 times, and you can repeat that. You can see that there are so many things that you can do for all the different parts of your body, and this is how we bring about a whole body relaxation using PMR. So you can something easy that can be taught to patients as well. Okay, otherwise, they can also listen to sleep meditations like my body scan, which I like very much. This is one that I recommend called Smiling Mind Sleep Meditations. Okay, so I'll just like to use the rest of the time to talk about sleep disturbances in dementia. Sleep disturbances is going to be even more prevalent in dementia. You can see that 1 out of 4 elderly with dementia, 4 out of 10 actually, up to 4 out of 10 older adults with dementia is going to experience some kind of sleep disturbances, and this could include increase in sleep duration, increase in the number of awakenings, and also increase in time spent in stage 1 sleep, which we know is that very drowsy stage in between sleep and wakefulness. Okay, And these changes in sleep regulation is really due to the dementia, the deterioration of their brain structures, as well as the decreased supply of certain neurotransmitters that are relevant for sleep, is making it harder for them to regulate their sleep schedule and circadian rhythm. All these problems can contribute to restlessness, wandering, accidental falls, and also, as Dr. Ng mentioned, high levels of caregiver stress for both our family and professional caregivers. Sometimes people might also group sundowning as a form of sleep disturbance in dementia. And sundowning is also very common among our patients with dementia, whereby you don't even see problems happening at night, right? It's already happening earlier in the evening, whereby patients are exhibiting increased confusion and agitation during that period of time. So then we also need to intervene for sundowning as well. But today I'm just going to focus a little bit more on sleep, and I want to bring your attention to evidence-based intervention that we can do for persons sleep disturbances in dementia. So I want to bring your attention to a Cochrane review. So these are large systematic reviews that are done that looks across all the literature to look at what are some of the effective non-pharmacological interventions for sleep disturbances. You can look on the right side, right? That these are all the kind of interventions that clinicians and also researchers have tried. They include things like light therapy and sunlight exposure. So basically putting people under bright light to kind of bring about and regulating their circadian rhythm also, because light actually stimulates wakefulness in our body. People have also tried physical activity, social activity, caregiver skills training, incorporating more consistent bedtime routine, decreasing the use of sleep disruptive nursing practices, decreasing noise and light at night, decreasing daytime in bed, trying massages, motion monitoring system, and even transcranial electrostimulation. So when compiling all this evidence together, this Cochrane review had found that there was lower evidence for light therapy, daytime sleep restriction, back massage, and all that. However, they found better effects for physical activities. They found that if residents or older adults with dementia were to be engaged in more physical activities, they will reduce the time awake at sleep. If they were to engage in more social activities, it will increase their nocturnal sleep time. And lastly, if we were to enhance more caregiver skills and caregiver interventions, it can also help with such sleep disturbances. So then I went to look at some studies, some specific studies for what kind of physical activities or what kind of social activities that they were doing. So in this particular study, to help with nocturnal sleep time, what they did, right, was actually, you can see that they did high intensity physical resistance strength training for 3 days a week, okay? So you are also thinking about how much or how frequent physical activities these older adults with dementia need to do. So in this case, they were actually doing physical resistance strength training for 3 days a week, and then they also do 2 days of walking for up to 45 minutes. They also had social activity for 1 hour a day for 5 days a week. And if you know the older adults are able to engage in this frequency or this dosage of physical and social activity, then their nocturnal sleep time was actually significantly increased than those people in the control group. So they found that such physical resistance strength training plus walking plus social activity actually improve sleep in the nursing home and those people and the residents also. Okay, what about education for carers? So another study found that if we were to educate caregivers with a sleep education program, such as talking about what are the common sleep problems in dementia, teaching teaching nursing staff how to do sleep scheduling, teaching nursing staff how to recognize what are the problematic or triggers that are affecting insomnia, and then problem solving these challenges, teaching nursing staff how to review the sleep plan and problem solve these challenges, as well as to develop individualized list of activities that can be implemented during the day to avoid napping times. Then all these combined together can also empower professional and also informal caregivers on more things that they can do to help with the sleep problems. Yeah. So I guess coming back to Dr. Ng's case, for the gentleman in the nursing home, as much as possible, it is very important to try to incorporate the same sleep time and wake time. As well as to increase the physical and social activity level. And one might say, oh, I've already tried to ask him to be engaged in physical and social activities. Then my question to you is, are these social and physical activities adequate to meet his unmet needs, right? Because we need to design physical and social activities that are aligned with their preferences, their background experiences, and something that they will be motivated to do in order to avoid and prevent the daytime napping. So it brings me back to the question of what are these gentlemen's unmet needs that is causing him to be kind of like almost wandering around at night during sleep. It could be due to his background of being destitute, of being homeless. Maybe he had the habit of walking around in parks at night. We don't know. So there are many information that we can find out as caregivers to tailor and implement more person-centered care for the specific resident themselves. Yeah. So this brings me to the end of my presentation. If you like my slides, you can access it on my website over here. I've already uploaded it over there. Thank you so much.
Thank you, Zaylea. That was excellent. Clear
Thank
and
God.
very
I managed
informative.
to do it in time today, so I'm very happy.
And it's very practical, especially when you discuss about the sleep journal.
Right.
Um, yeah, I have a question about sleep journal. How when
Yes.
your patient who actually documented her sleep, right? And then
Mm,
there was awakening, and then
yeah.
were able to capture the period when she was awake. Did
Yes.
she
Yeah.
actually check the clock and clock it into the journal? How did you capture this information?
That's right. That's right. I did mention, I did tell her do not watch the clock, but so sorry, let me just bring it back
Yeah.
to this part here. So in order
Yes.
to create a graph like that, right, I
Yeah.
actually had her document her a sleep diary or a sleep journal for 1 to 2 weeks to
Um,
have a consistent pattern. Then it is only after we start to implement this sleep restriction that I told her there's no need to watch the clock anymore lah, because now we kind of already have a good screenshot of what your sleep pattern is like.
so at the initial phase when you're trying to collect the data,
Yeah.
she would be asked to watch the clock lah, in a sense, to,
Yes, yes,
to
yes,
write the
yes.
timing there.
That's right. And it's okay to watch the clock at that time because her sleep is disturbed anyway. So uh, so for
Okay.
the first 2 weeks we can do that. So I'm not sure whether some nursing homes may be able to implement like a sleep chart or for healthcare professionals to better understand the sleep patterns.
Yeah, I
Yeah.
think a lot of nursing home, most of the time, majority of patients have some kind of dementia. I mean,
Yes, yes, yeah.
generally, if they are
Yeah.
not, then it's still possible. Most of them are still living in their own homes. So people living in the
Mm.
nursing home tends to be very disabled. So I
Yes,
think it's a
yes.
different approach, I suppose. You
So
mentioned something,
definitely, yeah.
yeah,
They
about
cannot.
controlled environment. It's going to be quite a challenge for nursing homes.
Definitely, definitely. Yeah, so there are so many limitations, unfortunately.
Yeah.
Of course, the residents with dementia, they cannot document their own sleep journal. So
Yes.
the caregiver may have to do it for them.
Yeah.
Um, and of course, it will disturb the caregiver's sleep lah, but hopefully it will pay out in the long run.
Yes.
And secondly, with the environment, yeah, unfortunately, we are not able to keep it quiet or dark all the time. So we may want to try to provide the tools like the earplugs, the eye mask. These are just some things to
Yeah.
try to compensate, yeah,
Yes.
for the environmental challenges. Yeah. Mm.
Thank you. Today
Yeah.
we don't have anyone putting up on the Q&A.
Okay, no problem. Yeah.
But
Mm.
Zaylea, the first case I presented, right, that 88-year-old
Yes.
gentleman, let's say using the approach I was saying, this gentleman has got mainly hypertension, impaired glucose tolerance, have got this insomnia since his early 50s. Light
Mm.
sleeper, waking up at night. Although nocturia is 4 times a day, 4 times at night, there's a prostate problem, but apart from the nocturia, there is not much of a prostate symptoms. So the nocturia arguably maybe not due to the prostate, but because of his light sleep. And you wake up in the middle of the night, then you think
Yes,
that you want to
yes.
go to pass urine. So how
Mm.
would you say manage a case like that if he presents himself in your clinic?
Yeah,
ABA, independent, able to drive. Yeah.
yes, yes. So, I would still go about using the CBT-I approach that I presented earlier. So,
Yeah.
after all, cognitive behavioral therapy for insomnia, CBT-I is the gold standard approach to working with insomnia disorders, and
Yeah.
therefore, I will still try to elicit, some of his sleep patterns,
Yeah.
and really try to find out whether is it the prostate problem, the
Ah.
urinary incontinence that is causing him to fall awake. Because
Yeah.
I have some patients, right? They also have this incontinence problem, but they can fall back asleep.
Yeah. Yeah.
So that is not an issue. But let's say this person is really struggling to fall back asleep, then we need to find out what are the triggers for
Yeah.
him not being able to fall asleep. For example, worrying about his health,
Mm.
or using his phone, not getting out of bed after 20 minutes and trying again. Those kind of things to strategies to try out. Yeah.
I think what helped for him, I didn't know
Mm.
much about CBTI, although I've heard of it. But
Okay. Yeah.
what helped for him was I told him that it's common for people above the age of 55 to start to have this insomnia problem.
Yeah.
And
Yeah.
then
It
when he
is.
heard that, he was very happy. It's like a great relief, a burden off his shoulder. Because for a long time, he was frustrated with his lack of sleep. But when a
Yeah.
doctor told him that it's quite normal, then he became okay.
That's great. That's great.
Yeah,
Yes, yes.
yeah.
So the validation helps also.
Yeah,
I
it's
also
sort
have,
of like thought
yes,
challenging. It's similar.
it is. I think you are challenging his
Yeah,
his thoughts on the spot also.
yeah.
Some of my patients insist that they must sleep for 7 hours, 8 hours, otherwise there's something wrong with them. But actually, looking at the statistics, actually 5 or 6 hours is sufficient already because the activity level during the day decreases so much. So they actually don't need that much sleep at all.
Yes.
Yeah.
Maybe I have a last question since
Yeah.
nobody is asking, but it's about dementia. Say, because dementia and sleep-wake reversal is so prevalent in nursing
Mm.
homes, and based on what you shared just now, the Cochrane reviews, physical
Yes.
activities and social activities,
Mm.
as well as carer interventions. The carer intervention
Yeah.
part is not very clear,
Mm.
even though I tried to read carefully your slides. So
Sure,
how
sure.
would you advise? Say, I mean, majority of nursing home in Singapore do not have single bedder, one person in a room.
Of course.
Most of the
Yeah.
time, it's like a group of people sharing the same ward.
Mm.
So that you can have nurses who can actually at a glance can have a view of a lot of seniors at the same time. So how would you say advise a nursing home managing insomnia among people with dementia generally?
That is a very broad
Using
question
the
to answer.
examples you gave just now, how would
Yes,
you
yes, yes. Yeah. So, if we were to look at the evidence-based approach, right,
yeah,
we definitely want to try to implement a consistent sleep and wake time.
yeah,
However, every individual is very different.
yeah,
And that's why when we are talking about carer interventions, it's more about
yeah,
upskilling, basically upskilling our nursing care staff,
yeah,
or any other staff lah. It could be family caregivers,
yeah,
nursing care staff, to teach them on identifying some of these problems that might be limiting the patient's sleep. So yeah,
okay,
so we want to identify some of these challenges. So these challenges, right, it could be anything in from like
yeah,
pain that is limiting sleep. It could be urinary incontinence, so medical problems,
yeah,
to psychological problems like worry, feeling
mm,
depressed, to their background history. Maybe they are just
yeah,
someone who maybe used to be
like our,
yeah, night owl or work night shift,
yes,
they don't sleep at night. And therefore, with dementia, they kind of go back to their past history, right? So
yeah,
yeah, I had someone who worked as a um security guard, night
yes,
shift. So of course he want to wander around at night, right? And we preventing him from doing that is kind of like going against that person-centered care. So we
yeah,
need to find honestly, the nursing homes are also limited by manpower
yeah,
numbers lah. So it's a bit challenging on that. But the whole idea is we want to upskill our staff so that they are
Yeah.
able to identify some of these triggers, because if you know the triggers, then you can target them better.
So many of us in healthcare, the A&E doctors and the nursing home nurses, I think we are at
Yes, yes,
risk
yes.
of having insomnia in the future when we develop dementia.
I think someone might have done a study on that. Yeah. Yeah.
Christina, do you have any thoughts or questions for Zaylea?
Yeah, I think there was a very useful thought. Thanks very much. Maybe also just to advise us in general when we see patients who are, I mean, they're already on a lot of medications.
Yeah.
How would you also time the medication so that, you know, all these non-pharmacological interventions will kick in like appropriately?
Yeah. So I do think that they go hand in hand, because the sleep medications is important to help um the residents or the patients gain more confidence that they can actually sleep. Because if we just take away the medication, I teach them these skills and they are kind of combating with the biological part of the problem, right? Then they are also not going to be motivated to continue this non-pharmacological strategy. So usually the sleep medications help, but if it's more of a PRN, right, then actually we can try to do more non-pharmacological based lah. So trying to implement all the strategies, like you've tried your relaxation strategies, you've tried the meditation and everything, and it still cannot work, then okay, we can bring in the medications part again. Yeah.
Thanks, Elliot. We have a
Thank you.
question on the chat group.
Sure, sure.
So obviously it's from a colleague of ours, fellow nurse or doctors here. Usually in a talk like this, we also think of our own family. So apparently her mom,
Yeah.
86 years old, at home with helper,
Yeah.
prefers to lie down instead of sitting or in the daytime or nighttime. So very lazy, so-called lazy, you know, to do exercises, only do like 5 minutes. I think it's very typical of a lot of
Yes.
seniors. You think that they should exercise, should socialize, but they just don't feel like doing that. And so also having dementia. So how do we, her LDL is dependent. So how do we help somebody? I mean, they're physically disabled. It's very hard for them to do exercises, and they've got dementia, and also
Sure.
maybe hard for them to socialize. So how would you advise somebody like that?
Yeah, I'm wondering whether for Angelica's mom, does she also have sleep problems? Or she's actually able to sleep for both day and night. It's just that her activity levels are lower
Yeah.
because of, you know, her mobility issues and things like that.
She didn't say she could sleep, but just say she likes to lie down. Yeah,
Okay,
so she has,
she's also having sleep problems. So I suppose difficulties falling asleep then.
yeah.
Yeah. So, I mean, for someone like this, I would firstly try the approach of those sleep meditations first. Maybe listening, because actually, even if you try it yourself, right? I've done it with my patient and they just fall asleep in front of me because it's like just too calming
Sleeping.
already. And also the sleep meditations require you to focus on just the bodily state and just
Mm,
calming the mind down. So it doesn't necessarily need to be the body. Of course, the body should have a certain level of fatigue lah to accumulate the sleep
yeah.
debt. But maybe if the mind can also calm down, then it can also help. So yeah, try those YouTube narration of sleep medications, body scan, deep breathing, that sort of things to try and help first. Yeah. But otherwise with activities, maybe you can engage your OT to talk about it the next time, because it really needs to be very person-centered lah. Otherwise, they have no
Yes.
incentive to do it.
Yeah, and also need a lot of effort. I
I mean, I
mean,
used to like
Yeah.
my late mom was also having a lot of sleep issues, so I used to just ask the helper to wheel her into the sun every day, with just so that even if she's not very active, but at least she gets some sunlight
Yeah,
and
that's the light
light
therapy
the
part.
yeah.
Yes.
Yeah.
yeah. Okay, so maybe we are overrun by 10 minutes or so, which
Yeah.
is great. And anyway, I like to express our appreciation and gratitude to Zaylea. This is all pro bono, and her contribution to all of us to enhance our learning. And as a doctor, I'm very grateful to be re-educated on non-pharmacological approach, because we all know, prescribing for frail elders, they're full of issues. And of course, there are many medications you can use, but there are also many side effects, a lot of drug interactions. So it's always better to try the non-pharmacological approach first. And thanks, Zaylea, for your contribution to our continual professional education. Thank you.
Yeah, thank you for inviting me again.
Thank you very much.
Yeah.
Thanks, everyone. See you
Okay,
again
have
next
a good
month.
weekend. Yeah.
Thank you.
Bye-bye.
Bye.